if you're not delivering the best care for the patient, you're falling short. So you have to come up to speed with how to approach a case in order to do it the best way.
Hi, welcome to Slow Fix Conversations. Today my guest is Dr. Sewanti Limaye. She is Director Precision Oncology at Sir H.N. Reliance Hospital and Research Center in Mumbai. So Dr. Limaye is a global leader in this field, which is really the new frontier of cancer treatment, precision oncology. So let's dive into the conversation and let Dr. Limaye take us through what is precision oncology and why cancer patients, new cancer patients and their families should be asking about precision oncology as an option for them. So let's dive in to know much more about what's happening in the world of cancer treatment and cancer care. Thank you so much for your time, Dr. Limaye. Yet again, very good to meet you. And in a different setting, which is so heartening, right? I've been your patient for the last 7 years and I haven't seen you as a patient in a while.
That's a wonderful thing, Sanjukta, isn't it?
Yes.
That's the wonder, and of course, you're my win. So it's incredible, incredible.
Your time is precious, so let's sort of get to it. I mean, in your words, just tell our viewers what is precision oncology and how is changing things for cancer care and treatment.
So, Sanjukta, precision oncology is an orientation. It's an approach. And the approach to that patient becomes different right from the get-go, how you look at that case. This orientation did not develop overnight. I would say this is decades worth of exposure to how cancer is caused, what entails biology of cancer, and the fact that it can be treated differently if you orient yourself like that. So if I look at a breast cancer patient, my first question in my mind is, how old is this patient? Is there a family history? And what other malignancies has the patient had? If there is a 27-year-old coming to me with a breast cancer and there is a maternal aunt who had breast cancer recently, the immediate thought that goes in my head is that you have to test the patient for hereditary breast ovarian cancer syndrome. Earlier, we were oriented like this mainly to understand whether the treatment, the diagnosis could be different. But now, we're all oriented to the fact that the treatment can be different so that you don't waste the patient's time, energy, money, and emotional quotient. And that's why I say it often that there is no other way to treat a cancer patient than the precision way. So I think we are very far from that. Precision actually does not just entail non-chemotherapeutic approach. That's why I always say precision is no different treatment. Precision is the same treatment done in a better way. When we look at targets in cancer care, the current targets that we can treat with targeted therapy or immunotherapy entails around 1/3. So 30% to 40% of patients will be eligible for targeted therapy or immunotherapy and will not need chemotherapy. What does that mean? That 70% of our patients or 60% of our patients are still being treated with chemotherapy. So precision then, to me, also means doing the chemotherapy right. The approaches that we have right now are mainly, if there is breast cancer, this is the breast cancer combination protocol for chemotherapy. If this is uterine cancer, this is the chemotherapy protocol for uterine cancer. All these cancers will have, and certain types of lung cancer may also have the same chemo combination. The ovarian cancer may be different from the uterine cancer, and the lung cancer that you're treating may be very, very different from the uterine cancer and ovarian cancer that we are treating. So, is there a more nuanced way to figure out what would treat this cancer the best? And is there a nuanced way to figure out what would treat this cancer in this particular patient the best? It should come down to the individual, shouldn't it? It should come down to what works best for that patient. If someone is reporting urinary infection, you ask them to wait. You give them a generic antibiotic, but you quickly take the culture prior to starting the antibiotics because you want to figure out whether their bug is going to respond to this particular antibiotic. Right. We don't do that with the chemotherapy. Yeah. We leave the patient in limbo. We're giving chemotherapy. We don't know whether this chemo is going to work for the patient or not. And it's only after the fact when we scan do we understand whether the chemo worked or not worked. So can we figure out a more precise way of doing the chemotherapy, because 60% of our patients are still going to receive chemo. Yes. Because right now, anyone who has lung cancer or anyone who has ovarian cancer may get the same regimen. And only after the fact you will figure out whether it's working for them or not. So technology is still short. When we talk about being precise, we also are talking about figuring out the best chemotherapy for the patient.
So it comes down to the individual.
So all these tests are under development. That is why they are not being practiced very routinely. Still, because I belong to that mindset where I would like to know the disease better, I do chemosensitivity analysis, and specifically in patients who have not responded to the frontline chemotherapy regimen. So I am a sheer optimist, and I look at the glass half full, never half empty. And I have seen tremendous amount of change. I've seen cancer care getting revolutionized. I also feel that the masses are actually waking up now and paying attention, taking heed to what is happening. I feel that cancer is an epidemic. It's only coming to its full numbers as we go. And we saw one epidemic just play out with COVID. Yeah. And now when I turn around, each family appears to have been touched by cancer in some way. You know, someone's mother, someone's aunt, someone's uncle, someone's friend, someone's child, someone's wife, someone's spouse, younger patients, elderly. You know, it really, I feel very strongly cancer does not discriminate. It touches every family, every life. And the Globocan numbers, if you look at the Globocan numbers for 2023, and I used to use a dated slide from 2018, and I would say 1 in 2 men and 1 in 3 women would be touched by cancer in their lifetime. And when I look at the Globocan data of 2023, it's the same numbers. 1 in 2 men and 1 in 3 women would be touched by cancer in their lifetime. And these numbers are very big. And that's the number that I see playing out even in the society, in the community. Earlier, and even now, in a lot, in parts of India, we know that cancer is a taboo. But I've also seen a lot of awakening. I've seen awakening in the youth. I've seen awakening in the responsible middle-age group. I've seen people coming out and saying, how can I do screening? What can I do to get past my initial hurdles? What do I need to do to be tested? What is the testing that I should be doing at this juncture in my life? And I find that phenomenal because earlier those questions were not coming. Now people don't know what testing they need to do, but they are seeking the testing. because especially after COVID, where people got out and got the vaccination, there is a sense of healthy lifestyle that is being projected.
The wellness industry.
The wellness industry has just exploded. And as this gets bigger, you see people waking up and saying, we really don't want to lose lives to cancer. And can we do something to prevent it? And so I most certainly see an awakening. Yes. So, the first thing I would say is when we think of cancer, we think of death and dying, and that's something that we should completely disassociate ourselves from, because there's a lot of hope, there's a lot of positivity, there are lots of good results happening with cancer. So the first thing that should come to your mind is no longer death and dying, but cure. I have to seek cure. I have to get to the right doctor, I have to get to the right center. I'm going to get better. That's the first feeling that one should get. But under that feeling, then you have to put rapidity of care. You cannot delay seeking diagnosis and seeking therapy. In that, I tell patients now, and the masses, this is what I go out and speak on, that earlier, when someone came down with pneumonia, they would go to their GP, and their GP would say, you need to do a chest x-ray, you need to do blood tests, and then we're going to put you on antibiotics. So it became ingrained in your mind that if I have pneumonia and fever, I'm going to get blood test and I'm going to get chest x-ray and I'm going to get antibiotics. This fact became known in families. It became a common thing. Similarly, when someone gets diagnosed with cancer, it became a common thing for them to get blood tests, get scans, maybe get surgery. But nobody talks about genomic analysis. Nobody talks about understanding the biology of their disease. But I've been now really trying to raise awareness for people to demand the testing. So they should ask the questions like, do you need genetic test for my disease? And they should start factoring in tests beyond histopathology. So biopsy and histopathologic testing.
Biopsy, right?
So biopsy, when you do biopsy, you send for histopathologic testing. Beyond histopathologic testing is the genomic analysis or biomarker analysis with which you understand what's the therapy that's going to work best in that particular patient. There are certain tests that are done just on blood, and they could also guide whether a person has disease running in their family, they should be treated differently. There are different drugs for that. There are certain tests that should be done, preventative measures that should be taken. So being oriented to that, if someone has cancer, they are going to get genetic test done. If the doctor doesn't do, they have to ask. They have to seek. They have to feel empowered to ask that question, factor in funds separately to do that. And there are many and more labs in India that are internationally accredited. They are of world class in a very, very frugal way. So I think there are two areas where we need major support. One area is in routine cancer care delivery, where government is already playing a very big role, and that role will only enhance. But I think India has already woken up and realized, and a lot is being done from the central leadership to that effect.
Like in government hospitals?
Government hospitals, okay. Prime Minister's fund,
okay. Yeah.
That covers cancer care. So some basic care is now being covered by the Prime Minister fund.
Right.
Beyond that, I think there is a huge world out there that is waiting to come to India, which we have to allow to come to India. Novel drugs in cancer care are funded by clinical trials, and those sponsors are actually pharma companies. When they go to the West, where patients have enough and more access to cancer care, they choose. They may have clinical trial availability, but they choose whether they wish to participate or not participate. For us, those clinical trials could actually be access to cancer care. And many of these trials are not first in human trials. They are not experimentation happening on our patients. These are established drugs that are already, you have figured out the dose, you have figured out their side effect profile, they've already been shown to be active in that particular disease condition. And they are access to cutting edge medicine in oncology for our cancer patients. But because this trial is not available here, we cannot offer the therapy to the patient free of cost. When you have a clinical trial running, and let's say there is a breast cancer clinical trial running for triple negative breast cancer. Triple negative breast cancer responds to chemotherapy, it may respond to immunotherapy, and so the patient should be given chemotherapy, immunotherapy, both. But immunotherapy in India is only affordable by 1% of patient population because you have to purchase it. No one is funding. So the patient has to pay for it. And that 1% of patient population is only able to really afford immunotherapy. I feel if you have access to clinical trials, there are so many clinical trials out there, multinational trials running outside of India. Some of them are also coming to India. We really have to make our clinical trial acceptance rates much higher. The conduct of clinical trials have to be done in a very, very transparent way. Then you attract the international pharma, and it's an amazing case of demand supply, right? We have the demand, they have the supply. They need the patients on the trials because they need the trial data, and we have the patients seeking novel cancer care. Many clinical trials are actually also establishing the dose and efficacy. But though, India is still not that mature to allow those clinical trials to happen. And we are also a very sensitive community because we are underprivileged. So we are already defensive that we don't want our subjects to be, so-called, within inverted commas, experimental subjects. Now, when we have that kind of a defensive sensitivity, we really can't, to the masses, have early phase trials where you have first in human trials, because you are at risk to be getting a very negative approach from the patients. So I think where we need to break barriers first is by bringing advanced trials that have already been established in early phases to be safe. Those drugs are safe. They only need to be given in addition to standard of care therapy to enhance the rates of response or survival to standard of care treatment. And those are the novel drugs. Enhanced data from trials that have already been run, data that has already been established, not the first experiment on our patients. And then you are able to provide these very, very cutting edge drugs to the patient as a part of clinical trial, and there's no longer an access issue. So two ways of approaching cancer care in the immediate next several years. One, of course, the government has to enhance care and support, and second is to allow sponsorships to happen where novel cutting edge drugs can be brought to India in form of clinical trials. There are more mature clinical trials. Drugs have already been tested, side effect profile has been described. You can talk about the side effect profile and expectations with your patient. You know what to expect, and you should have a robust clinical trial environment to run these trials with full support and full transparency. So, when we have to study a particular type of cancer, and you are struggling with the numbers, and you'll get the data in X amount of time in the US because of the population density being low. We already have the disease. We already have the representation of a particular cancer. For example, oral cavity cancer. India is number one country to represent oral cavity cancer. Has the research happened enough to eradicate oral cavity cancer? No. We haven't taken enough preventative measures. Once the cancer has happened, we haven't done enough to understand how the disease biology of oral cavity cancer in India is different from the rest of the world. And what would work for our patients that would be different than what is happening in the West. We continue to use their protocols. We continue to use their doses. We have never tested our patients. If you ask each one of us oncologists, we never utilize the same dosages as that is being given in the West, because the way we metabolize a drug is very different than a Caucasian person would metabolize their drug. So the nuances are so deep. But when you look at the collaboration that has happened, or at least the promised collaboration that is about to happen, it is something that fills you with hope. Because, and hope with a basis. Because what one sees is we have the subjects, we have the research arena, we have so much that we can bring back to the world in terms of information on a particular type of cancer. That information can be clinical, that information could be genomic, that information can be beyond genomics in terms of biomarker discovery, and also AI-based information. So I think technology and AI are our savior. Because when we just talk of precision, we talk about N of 1. Each patient is special, and you have to design the treatment strategy for that patient. We have 1 billion and more population. How is it feasible? So what AI does is that if you have one patient experience that is like this, and a particular genomic finding that looks like this, or a particular clinical finding that looks like this, and it is in this part of the world, what is a similar patient with similar findings in another part of the world getting? What was the diagnosis? What was the treatment? How can we help our patient sooner, quicker than that patient? This is just one example I'm giving. Another example is what I mentioned earlier of chest X-ray based lung cancer diagnosis. So what is the easiest lung screening tool that we have today?
It's X-ray, right?
It's X-ray, just X-ray. Now, can you train by doing X number of chest X-rays? Can you train the software to pick up a nodule on the chest X-ray and predict by how it looks to say whether this is cancerous or non-cancerous, malignant or non-malignant? And if the software is able to at least sieve through thousands of X-rays to tell you whether this looks suspicious, at least you can proceed with doing additional testing for that patient, and you won't be wasting your resources on testing that many thousands of patients or subjects to understand whether they have lung cancer or not. You now would just have a cohort of those patients who have the chest X-rays that look suspicious. Similarly, there is a lot of things happening in terms of examination of oral cavity. I mentioned that earlier. And how an oral ulcer looks like, and whether by just putting a particular dye on the surface of it or a laser ray and collecting the information, can you put it in a slot where with AI the machine is trained to tell you this looks suspicious and this doesn't.
Is that already in place, or it's something we can expect?
So these are measures that are happening. These are initiatives that are taking place. I don't think they have become a standard of care yet. They are going through what I would say clinical trials or experimental measures, but they need to be more enhanced. A lot of the AI-based measures are already in function, and we all know about ChatGPT and how our lives have been affected by that. But I think to take it to the next level, incorporate these in our routine daily practice, we are still a little away from that, but each one of us is witnessing such initiatives happening in their area of work, and we are witnessing in many areas of cancer care. So Karkinos is doing wonderfully, and they have a lot of promise. They have.
What exactly is their work like?
So they are working in two major areas. One area they are working on is in diagnostics. So they are participating in very high-end cancer diagnostics, genomic analysis, and in addition to doing routine clinical lab work where genomic analysis is being done for cost, they're also engaging in very large cancer diagnostic genomic research efforts. So in the next year or two, the kind of work that will get published from their lab would be path-breaking. They're engaging in such kind of research efforts, and some of their work is happening in conjunction, in collaboration with international leading international cancer care centers, and so there's a lot to watch out for them on the horizon. And then of course they're also very active in cancer screening efforts and cancer care delivery. And the cancer care delivery that they are focusing on is largely in hard to seek areas. So they have gone outside of the major pivotal areas where cancer care is already at a certain level. And so they are reaching out to the masses in hard to seek areas and trying to deliver world-class cancer care in those areas. And also large effort in cancer screening. So Karkinos is definitely a company to watch out for, and is going to be operational, already operational I would say, in both the diagnostic as well as the therapeutic fields and cancer care delivery. Cure AI is another company that I have learned of, which is doing the lung cancer screening initiative with chest x-rays. And they are programming their softwares to try and understand the behavior of the chest x-ray in terms of malignant, non-malignant, and whether they are able to predict at large whether there is a lung nodule that looks cancerous or non-cancerous, and help with the early diagnosis in that way. There are a lot of liquid biopsy testings happening, and really companies that have gone beyond the routine in a path-breaking way to figure that out by just a blood test. And I think I'm a big believer that this is going to bring about a paradigm shift in cancer diagnosis.
Can you tell us a little bit what exactly is a liquid biopsy?
Yes, so liquid biopsy is just a blood test, right? Either you take 2 tubes or 3 tubes of blood test in specific containers that are provided by these companies, And one of the international companies that has really gone out and established a test for such kind of cancer diagnosis with a sensitivity rate of 40% is a test called Gallery. Grail is the company, launched a test called Gallery, and the Gallery test is only available in the US and now as a research method in the UK, where the test itself has 40% sensitivity and 40% of cases is able to predict just by doing a blood test X number of cancers. It's able to tell you with a blood test. And you may have that. Only in a very small percentage of patients is it able to predict that you may be able to, that you may be predisposed to it, where the scan comes out negative, right? So when the blood test is positive and the scan is positive, it's able to predict early, or maybe it predicts in a patient who is not disclosed in an advanced stage. But in certain percentage of patients, the blood test comes back positive and on scan there's nothing. There it's able to tell you that you are predisposed, that someone is predisposed to that test.
Can you then arrest the disease, or you have to wait for it to manifest to treat?
So the test is still early. We still don't know what to do in those patients. Because I'm on the advisory for many such companies, we still don't know what exactly has to be done with those patients who are manifesting. These tests are so sensitive. They are picking up circulating tumor DNA in blood where the patient may not have a lesion. And so you have to track them, and the world is trying to understand what exactly has to be done for those patients.
So the advantage, I guess, is to you screen.
You screen.
Regular interval.
You screen at a regular interval. You try to figure out. You stay ahead of the curve to try and figure out what may be coming through. So Gallery is one test. And then there is a company called Datar Genomics. And that company is right here. It's a homegrown company. It's an Indian company. It's in Nasik. And they have 3 FDA breakthroughs already with screening tests for 3 different malignancies: breast cancer, prostate cancer, and brain tumors. Where in brain tumors you couldn't even, these are patients who couldn't get a biopsy. Without the biopsy, their cancers were diagnosed just with a liquid biopsy, just with a blood test. And their sensitivity rates are over 90%. And the test is called EasyCheck 360 here in India, and abroad it's called TrueCheck.
And how expensive are these tests? Very expensive?
So in India, actually, they are not expensive. I would say they're very economical. Excellent. So I'll give you an example, and with that I'll explain what ILON exactly does. So let's say I have a patient who I did a genomic analysis from Datar Genomics, and the entire genomic report is in front of me, or I even may have tested him from an international company called Foundation One, and the report is in front of me. The challenge of a precision oncologist is beyond the testing, right? Because now you have to interpret the test and give the therapy. And as I explained earlier, the treatments intersperse. You have targeted therapy, immunotherapy, chemotherapy. The precision approach does not mean you're going to avoid one versus the other. It is something that focuses on the best treatment for a patient. And it's a conglomeration of all that information to deliver the best care for the patient. When you have a patient and you have the test results from any one of these companies, whether it's an Indian company like Datar Genomics or Karkinos, or you have a test result from an American company like Foundation or Tempus, and you wish to piece it all together and give the right therapy to the patient, it may entail targeted therapy as per those reports, or it may entail chemotherapy as per the standard of care. It is an intermingling of all of that that should be then focusing towards delivering the best care and best outcomes for the patient. That's where some of the answers are not available here to us in India or to any one specific oncologist worldwide, where talking to each other and sometimes escalating the case to experts may get you answers sooner, quicker, and in the interest of the patient's best care. That's when we decided to found ILON, because no cancer case should be decided in silo. It should be a joint effort. It should be a group of physicians coming together. It should be done under the guidance of the people who have invested their time and energy to master a particular disease condition, and that should be their lifetime's work. So if there is any complicated scenario, any complicated case, any complicated question, that should be answered by that disease-specific leader. One of the biggest reasons to found ILON was the fact that when you have genomic reports that are so complicated, no one person may be knowing the answer. That's when people coming together or going to the final word, to the final authority, thought leader on that subject may be of huge importance and may save lives.
So ILON facilitates.
And then ILON facilitates that.
So you can consult an expert for your patients.
Yes. If you have a lung cancer patient where you're struggling with therapy and you have the genomic reports right in front of you, it's only shedding light up to a certain extent. Why did this drug work and then stop working? These are the findings. Can we do anything better for the patient? Is there a drug that would act very, very quickly in a patient? You take that question to the right kind of thought leader and you may get a recommendation that may change the life of that patient. So that's a very tough question actually, Sanjukta. And I say that because one thing I have realized is cancer has no rules. So we are all out there fighting this big epidemic, big war, and we have to put ourselves on guard. So to the young generation, my message would be really set out there to empower yourself with the most knowledge you can for cancer screening, cancer prevention, healthy lifestyle, and what can you do if someone gets diagnosed with cancer? What is the firefighting that is needed? Because the baton is now in their hands, in the younger generation's hands. And they need to be really up in the arms. They need to be aware, visible, empowered to fight this battle. Because that's how we are going to save more lives. So screening, when we talk screening, if the torch bearers are younger generation and they go out and they look for their parents, their grandparents, their cousins' parents, and they spread the word for screening. They spread the word for prevention. When we talk about what can prevent cancer, there are so many things that are enlisted as the classic things, right? Avoid alcohol, avoid red meat, avoid smoking. Yeah. And these things will prevent cancer. But then every now and then we get a person who has none of these vices and still comes down with a disease condition. That's where I say, look out for all kinds of symptoms. Don't belabor the symptoms and sit at home. Seek medical care quickly and get to the right kind of center right away. If there isn't diagnosis at home, don't panic. Get to the right doctor, get to the right center, save life. So still the liquid biopsy breakthrough, that trial has to be run in the US. Okay. Once the trial runs in the US, and Strand Genomics Strand is owned by Reliance, and Strand is also putting through clinical trials for liquid biopsy. Once these tests Any one of the tests goes through the FDA drill, full FDA drill. Can you imagine that the cancer diagnosis, screening will just be a blood test? It'll just become a blood test. I can't say too much about it right now because it's not FDA approved, but I fully believe in it, and I have started prescribing. Those who are in the US, I prescribe Gallery. Those who are in India, I prescribe EasyCheck. This, and many other companies are coming with that.
Okay.
And that's going to be the name of the game. So that's a brilliant question, and actually as we go along, Sanjukta, there's more data coming out, and some of the data is as recent as last year. We learned from a research that was done in around 50,000 subjects in the UK, where they found out that dust particles above 2.5 micron in size were directly responsible for causing a particular type of lung cancer. It's called EGFR positive lung cancer. It's a non-smoker's lung cancer. And guess what? In India, 50% of all lung cancers are non-smokers' lung cancer. And a large portion of this is EGFR positive. And there are many other lung cancers that are genomically driven, and they are as a result of environmental insult. So much so that there should be now a warning in different cities as to what is the time when their heaviest pollution levels are there, air pollution levels, and how and when should we be avoiding coming outdoors and doing activities, and at least mask up. And what are the measures that government would take to prevent such high pollution levels from happening? So I feel that this, other than tobacco control, we really need to set out and wage a war against the pollutants that are happening in the environment and the actions that are being taken at a central level to prevent such pollutions from enhancing, from increasing. And how could then we raise awareness in our youngsters, younger generation, in our youth, to be aware of that and prevent themselves from that. If there is a time when the smog level is the highest, don't go out jogging at that time. And so
and
such awareness.
For social media activism.
Yes,
it is.
It's a huge thing, and one has to take it up because we are seeing people who are not really engaging in any kind of cancer-causing smoking or alcohol or eating habits. Why are these people also coming down with such malignancies? And one has to then turn around and query each environmental fact to understand whether these are contributing factors.
Thank you so much, Dr. Limaye. It's always so wonderful and so hopeful and promising to meet you. And for us who've gone through cancer, for people who want to know more, prevent, thank you for your work. And let's keep this conversation going. I think it's much needed.
Thank you, Sanjukta. Thank you for having me and being a champion for cancer awareness. I know that at this juncture you've put in all your efforts in raising awareness, and I'm joining you here in your efforts further. And thank you.